Now with Dr. Ashraf Samir Rifai. Dr. Ashraf is a professor of endodontics at Al-Azhar University, Cairo, Egypt. Our lecture title will be Endosurgery, a Matter of Choice.
العفو بس والله نظن احسن محاضره. ربنا يخليك يا حبيبي والله كتر خير كتر خير. تاخدي الميكروفون بقى مني. اوكي ده معمولها عشان تبقى صعبة.
لا
اوكي
مش شايفة.
لا انا فهمت بس انتوا عندكم ضوافر احنا ده معمول للناس يعني هم عاملين كده مبهدلين اللي مالوش ايه ضوافر. هو كده One, two, three, testing. Okay, we're good. Yeah. شكرا. All right. Can everybody hear me? Yeah, كله تمام? All right. بسم الله الرحمن الرحيم. It's an honor for me to be here today in ITSEC 2019. Anybody who's anybody in Egypt has to take part of ITSEC, and this is my, I don't remember which number of ITSEC, but I'm always here and I always love to be invited. So ITSEC 2019, hopefully 2020 and all the way forward. Okay, I'd like to thank Dr. Abir, my chairperson today, and Dr. Hassan, he caused me a little amount of stress because I'm a little late. So I'm trying to push this lecture within half an hour, although it should take longer, so bear with me if I'm moving a little quickly. All right, the name of my lecture today is called Endodontic Surgery, a Matter of Choice. And this always brings me back to my first years in my career when I was working as an intern, and I really didn't know why I was doing things. I was just doing them because my professors or my peers were telling me, this is what you had to do. And when it came to endodontic surgery, we were very, very concerned about just getting into the surgery, doing a surgery. And I remember that this was the situation. I was being told by my professor, look, this requires endodontic surgery, go in and do it. I didn't know why I was doing it. What was the end result of me doing it? I just wanted to get in, open a flap, do an apicectomy, and close over, and then be happy and go home like I did something special. So that's the way we used to take decisions with regards to endodontic surgery when I was in the beginning of my career. And I'm sure this is a familiar situation with a lot of other people. All right, so this is Lubbock, 1964. This is out of a textbook, out of his paper, in which he outlines the indications and the contraindications for endodontic surgery. And there are a lot. That was 1964. In 2011, this is a review of the current best practices, there are only four indications. And the reason why this is because simply we have been exposed to a large number of improvements in technology. And these improvements in technology have made our treatment plans more conservative, have allowed us to do more non-surgical retreatment. So simply the number of cases in which we do endodontic surgery per year has shrunk. Okay, so what are the indications? 4. Persistent periodicular disease. That makes sense. You've done root canal treatment and the periodicular disease is still there. When a biopsy is required, that's self-evident. When perforation repair requires direct visualization. So if you have something that you can't reach through the canal, then you are forced to correct this perforation or this to do the repair from the outside of the tooth. And finally, when root amputation or root resection is required. So these are the indications in a nutshell. We don't have a large lesion. Long ago, they used to tell us, this is a big lesion. All big lesions needed surgical retreatment, and this is not true. All right, where are the contraindications? You've got some medical conditions will require that you cannot do surgical retreatment. Local anatomic factors like proximity to the mandibular nerve, proximity to the mental nerve, and obviously the skill and experience of the operator. This makes a big difference. I've seen some very big messes being done by newly grads who just want to get in there and do the surgeries. All right, so what do we classify corrective surgery, endodontic surgeries into 4 different categories. You have periapical surgery, replantation, corrective surgery, and incision and drainage. These are the 4 main branches. Okay, so case number 1. This is going to be a case-oriented lecture. So I'm going to be discussing my first case today. I called it, Oops, I Did It Again. All right? So let me go to the history of this case. It was a 43-year-old female. She was غلبانة. She didn't have much money. So she came to our clinic and we wanted to do some charity work. So her chief complaint was that she had a root canal treatment done before and the doctor tried to remove it, and she has a swelling in the vestibule. So when I took an x-ray, I see an overextended filling. You can also see here, it looks like a perforation because the doctor had a really large post inside, and he had a very wide canal space, and the lamina dura looks generally intact, looked okay. So what are the options? We have to imagine the long-term prognosis of a tooth like that with regards to restoration. Is it restorable? Is it not restorable? Should we just extract and place an implant? The cost-benefit ratio. In the case of a paying patient, he would have to evaluate the cost of retreatment, endodontic surgery, crowning, maybe crown lengthening, versus implant surgery, augmentation maybe, and then he'd have to make the decision based on the cost and the benefit. So we're really stuck here, and this patient, it was a no-brainer for her because simply she was limited means, she had no options, she wouldn't be able to put an implant. So in the end, I was like, okay, fine. I told her this is not a very good situation for us to restore, but she insisted, so I said, fine. I tried to remove the gutta percha coronally, apically, and I couldn't. You can see there's a trilateral removal here. That's exactly the position of the file in the picture. And I tried to remove it, but still, a piece of gutta percha was out apically. I couldn't pull it back in. So I did an MTA filling. I repaired the lateral perforation. You can see it over here. And I did an MTA filling with the purpose of, I'm going to go in, do a surgery, remove that overextended piece of gutta percha, and then everything would be fine. So here's the incision and drainage, that you always have to localize your apex. When you localize your apex, in this case, I could see the gutta percha out in the periapical area or in the vestibule. So I knew exactly where I had to aim, and I knew exactly where my gutta percha and my apex was. All right, I did a flap. I took my vertical incisions first. And nowadays, when I do my vertical incisions, I end them at a 90 degree to the gingival margin so that they're easy to replace. And in this case as well, I excluded the papilla. There was no point for me to include the papilla. It's a limited surgery. All I wanted to do was some apical curettage, remove that gutta percha from the apex. I know a lot of people like taking their horizontal incisions first. I prefer taking my verticals. Again here, 90 degrees to the gingival margin, and then curve back and take a rectangular flap. I prefer using rectangular flaps, not trapezoidals. And then, obviously, the horizontal incision will come next. Okay. Right. So we take the horizontal incision all the way to the next one. Sometimes you'll find that I'll repeat my incision within the first incision. This is to take a good hack at the mucoperiosteal. The mucoperiosteum sometimes is very resistant to the cutting, and when you come to reflect the flap, it tears. So it's good to have a nice, good cut of the mucoperiosteum. Okay, and then obviously after that, then we would have the reflection. Again, I take the corner of my flap. This is standard. You pull the corner. A lot of people like to use the back of the flap. I take my corner using the concave surface because it's easier for me. And then I'm pushing away the mucoperiosteum to expose the surgical site. Once I've elevated the initial part of my flap, then I'm probably going to reflect using a gauze to push that and do some blunt dissection and peel off the mucoperiosteum off the bone. Okay, so that's the reflection phase. So let's evaluate what I did with my incision. There's quite a big frenum over there. So for me to cut my vertical incision into the frenum wouldn't have been smart. It would have been really difficult to suture back, and it would also have been very difficult, probably it would scar after healing because the frenum would pull away from the flap. Like I said, I use a rectangular design, so it's limited, it's not wide, and I do not include my papillae, and I finish at a 90 degree to the gingival margin. Next phase would be the curettage. Now, when I reflected, I was quite surprised to see a very large defect here. Okay, a very large defect, you can see it. And I started curetting. I was more concerned about what I saw there and this black discoloration of the root than I was with what was at the apex. I know there's gutta percha outside there, there's no problem with that. But I was quite intrigued about what I saw on the labial surface. Yeah. So look at all that discoloration. That's probably black discoloration from the internal surface of the root canal because of the overpreparation and because probably bacterial percolation to the outside surface of the root, which leaves some pigmentations in the root structure. Okay, so obviously what do you see here? That was a vertical fracture. That's why there was loss of labial bone, and for some reason I didn't see it on the periapical X-ray. So if I had seen it on the periapical X-ray, I would have automatically told my patient not to waste her time on a surgical treatment. The only solution for a vertical fracture of this magnitude would be an extraction. So what now? Where do we go from here? So I told my patient the success of this treatment is very limited at best. This is a tooth which will be lost in a matter of time. Now, she considered the options. I don't have much money to pay for a treatment. I don't want to do an implant. I can't afford to do an implant. So her suggestion was just keep it closed. I'll maintain whatever I have until it falls, as anybody in that situation would do. So I said, okay, fine, I'm going to do that. So in the process of finishing off what I did the slight root resection, removed the gutta percha, and I resected the apex to the MTA plug, which I had already done before, so there was no need for a root end filling. It's already there, already done. But you can see that the pattern of bone loss, there's probably more than one vertical fracture. You've got bone loss all the way from the cervical to the apex, and then you'll get a magnified view of the apical prep, and you can see how big the canal is from the apical direction. Okay, so closure. Later, what I did later on was obviously I had to close over on the request of my patient. In this case, I did a vertical matrix from the palatal side. Now, I did that for two reasons. First of all, the vertical matrix suture is a very, very strong suture. It doesn't tear easily, especially in the area of the upper anterior with a low frenum. That way, you can expect that lip movement could easily tear my sutures. So in this case, I did a vertical matrix, and I took it from the palatal because I just got used to doing this since I took a soft tissue management course, that when you have your knot on the labial, it leaves a little scarring. But if you put it from the palatal, there won't be that much scarring. Because you'll see the final end result of the suturing process. Sorry, I'll go back there again. So the final end result of the suturing situation would be like this. I'm taking my vertical sutures. Suturing, I mean the vertical incisions, and you can see the suture here. See that? It's barely visible. And usually, if you have your knot on the labial surface, the knot sometimes creates a notch in the papillae. So that's the end situation of this surgery. Obviously, this patient is not going to live very long with that tooth. Okay, so let's do some case review. This is the situation. Now, when I look in retrospect, I see a slight widening of the periodontal membrane space, but nothing gave me a giveaway that it was a vertical fracture. Because if I had seen it on the periapical X-ray, I probably would have suggested that this be extracted or not to do a surgery. Vertical fractures may not appear on the X-rays. If I had taken a CBCT scan, that would have been a no-brainer, because in the CBCT scan, I would have seen the vertical fracture immediately. All right, Shannon Patel did research in 2009. This is really old research. He got cadavers, dead bodies, and he did this research in Malaysia. And he created artificial lesions in jaws of patients, dead patients. And they took periapical X-rays and they took CBCT scans, okay? And they compared whether the clinicians could discern the difference between if there was a periapical lesion on a CBCT compared to the periapical X-ray. So 25% of the time, the periapical X-ray, the doctor was not able to evaluate whether there was a lesion or not, while 100% of the time with the CBCT, we were able to, the clinicians were able to evaluate the presence of a periapical X-ray. And that's how important a CBCT is for, before you do a surgery, for planning. Because a case like this, I wouldn't have had to do the surgery, I wouldn't have put my patient under unnecessary risk. I would have suggested from the beginning, this is a vertical fracture, extract it or do something else. Okay, with magnification, the field of view becomes much smaller, and the need for large openings becomes less. The reason we used to open from flaps from the canine to the canine before was because I needed to elevate, allow light in, to be able to access with my big bulky material equipment. But now with magnification, I can keep my surgical sites as small as practical. Obviously, you need to consider the position of the frenum. You should always end your incisions at a 90 degree to the gingival margin, and whenever possible, exclude the papillae. Tearing the papillae is not something we would like. Again, I use the vertical mattress with from the palatal side to prevent the formation of scar. And here you can see that the suture is barely visible, and it's really tight. And obviously, nowadays I use either 5-0 sutures or 6-0 sutures, so the amount of post-operative scarring is much less, and the post-operative period is much less before we remove the sutures. Okay, so that's case number 1. Case number 2, roots, and more roots. So this was a case, a 46-year-old female. I remember when she came in, she was complaining of a swelling related to her lower first molar, I think, yes, it was the lower mandibular first molar. And she had a swelling from the lingual. I was a little suspecting, but usually we get our lesions from the labial, but in this case, the patient had a lingual swelling. And I took an x-ray and I could see some calcified canals, a crown restoration, and a loss of lamina dura a little bit, a continuous lamina dura, so there wasn't much of a lesion. So I was like, okay, this seems like an open-shut case, root canal, retreatment, and then patient's on her way. So I started removing, and when I started removing the material inside the pulp space, I found that the previous doctor had put in some sort of formocresol-based material, and the whole area was very, very calcified, full of black and white areas. It was very difficult to find the canals in the get-go. I found the mesiobuccal, the mesiolingual, and then the distobuccal and the distolingual. And you can see the extent of calcification here. You can see calcified material all the way inside the canal. This is all the way at the apex. And there was something else up there. I don't know what that was. So I started feeling a little uneasy. So in this case, I sent the patient for a CBCT. And this is the CBCT positioned at the same position as the picture. So you can imagine where we are during the process of explanation. So this is an axial view. We're going to move apical, and you can see there is an extra root. So you've got your mesiobuccal, mesiolingual, distobuccal, distolingual, and this extra one over there. And you've got a lesion around it. So that's probably where, this is towards the lingual, so that's probably what caused the lingual swelling. There. Okay, so this extra root is called a radix entomolaris or paramolaris, depending where it is. If it's towards the lingual, it's called an entomolaris. If it's towards the buccal, it's called a paramolaris. Now, this is a generally very rare situation. Now, if you look at the research, it was first described by Carbelli in 1844, and if you look at the percentages in different populations, it's 3% in a Palestinian population, 2% in an Indian population. In Egypt here, it was 0.023%. Marwa Sharan did this research out of Qanat Suez Canal University. And the highest percentage was found in East Asians, Chinese, Taiwanese, which is about 21% of the patients. So if you get a patient who comes from Chinese descent or Taiwanese descent, East Asian, you've got to keep your eye open for that radix entomolaris or paramolaris. It's very common in those populations. Other than that, you're talking about a very, very narrow percentage of occurrence in other populations. Okay, so there's the extra canal. You can see it now. And you can see here, as after I tried to clean out that calcification, I had a very hard time. The canals were really narrow, really calcified. I could barely get in, and I was unable to negotiate any of the canals to the full extent. So in this case, I looked at my CBCT again, and we moved further apically. And if you keep your eye on the radix entomolaris, you can see this. I saw this on the lingual surface. So this is a perforating internal resorptive lesion. So not only is it a rare radix entomolaris, also it's perforating, and it's an internal resorption case, which is also very rare. So the possibility of having a radix entomolaris with an internal resorption and it's perforating is next to zero. So it's a very rare case.
Dr. Ashraf, excuse me, 2 minutes.
2 minutes? Very good. So I have to move very quickly. I have 2 minutes. So that's what it looks like from all the views. And like I said, internal resorption is really rare. So where do we go to next? What are the options? You've got perforation repair and endodontic treatment, extraction and implant, and something else. So in this case, I decided to do a root resection, cut off that lingual root, and leave the rest of the tooth. The patient was barely accepting for me to do a root resection. I suggested a complete apical surgery because I was unable to reach the full working length in any of the canals. So very quickly, I'll move on. I bonded composite. I did the obturation to whatever I could obturate. And then I cured. And then I placed flowable composite into the orifice because I know I'm going to resect that root. So there was no point for me making it more difficult on myself to repair it during the surgery. So I filled the canal, maybe the first 1 or 2 millimeters with composite, and I cured it. In this case, I used a horizontal incision. I just made an incision, a crestal incision, and I exposed the surgical site. You can see a lesion attached to that radix root. And then resected the root. I cut out the root. So I had to separate it from the main part of the tooth, and this was guided by CBCT. There you can see it's separated. And then I'm just going to move down here because we're limited on time. Okay? And now I'm removing a little bone lingually because I need a place for the root to come out because there isn't much space. So I need to remove maybe about 1 millimeter or 2 of bone at the apical, technology. Dr. Hassan عمل لي stress. Sorry, I'm losing. Okay, so there, after that I'm pulling out the tooth. It's giving me a hard time because it's a very limited field and it's very difficult to pull out that root. And there I was managed to pull it out with a lesion. You can see there's a lesion attached to it. All right, and then after that I recontoured the surface of the tooth from the outside just to make sure that it's smooth, doesn't create a food grabbing area, and then closing off with simple sutures. Okay, so there's the piece of the tooth that I took out, the root. You can see the perforation and you can see the lesion. All right, so that's the piece of the root that we removed. All right, now this is the X-ray pre and post operative. Obviously, I'm very upset with the root canal. I could not get any better than this. That was the maximum I could get with extension. But the purpose of this was to show that was the root exit or the orifice where I had filled with composite. Okay, and that's the position of the root if it was still there. Okay, and that's my final. That's the prep, the final prep. You can see good healing lingually. This was after my surgery for about maybe a month after my surgery. All right, so very quickly so that we don't take much time from anybody else. The incidence of radix entomolaris is very low. Again, CBCT here was paramount in my ability to plan and diagnose. Not all canals, calcifications are negotiable. This is something we all experience. And root resection can be a useful tool in the endodontic armamentarium. Okay, so 2 roads diverged in the wood, and I took the one less traveled by, and that has made all the difference. Robert Frost, American writer. So sometimes taking the unusual path may allow our patients to retain their teeth for a longer period of time. Thank you so much.
Thank you, Dr. Ashraf.